Good afternoon, everybody, and good morning or good evening, depending on where you are in the world. I hope you're enjoying London Global Cancer Week so far. It's been fantastic. My name is Kat Gord. I'm the Acting Deputy Editor at the Lancet Oncology, and it's my pleasure to introduce you to this session, the Lancet Oncology Commission on Medical Imaging and Nuclear Medicine. So this commission is a fantastic project that we launched in March earlier this year at the European Congress of Radiology, a virtual conference, as many of them have been lately. And it's an absolutely fantastic project which addresses the very important subject area of medical imaging and nuclear medicine and the need to improve access to and availability of medical imaging worldwide, because it has such an important role in cancer care. So just a few housekeeping things for this session. We have 4 fantastic presentations that have been pre-recorded, and we're going to run these back-to-back as videos. And during the presentations, you're welcome to submit questions on the Ask Question box on the dashboard, which you should see on your page. You also see a box called Related Content on your dashboard, and that will take you with a link to the Commission and also to the Lancet.com. And you can move things around on your dashboard to minimize or adjust any of the boxes as you wish. At the end of the session, we will run a Q&A with the presenters who will be joining us. So please do submit your questions throughout, and we'll address as many of these as we can at the end. So for the session today, we have 4 speakers who are the lead commissioners on this project. We have Professor May Abdelwahab from the International Atomic Energy Agency in Austria, Professor Andrew Scott from the Department of Molecular Imaging and Therapy and Head and Tumour Targeting Laboratory in Melbourne in Australia. We have Professor Rifat Atun from Harvard University in the USA. And we have Professor Hedvig Rikak from the Department of Radiology in the Memorial Sloan Kettering Cancer Center in New York, USA. So, without further ado, I'm now going to hand over to our technical team who are going to run the presentations. Thank you.
Hello, I'm May Abdelwahab, the Director of the Division of Human Health at the IAEA. And today I'd like to thank London Global Cancer Week organizers and Mark Lodge for the opportunity to hold this special session, and also to David Collinridge and Lancet Oncology Commission for making this commission possible. The report of the Lancet Oncology Commission on Imaging and Nuclear Medicine was published in March 2021. And today, over the next few minutes, I'll be presenting the objectives and the scope of the Commission. So the Lancet Oncology Commission on Medical Imaging and Nuclear Medicine highlights the need to improve awareness of and patient access to affordable and effective cancer imaging worldwide. The Commission discusses the range of medical imaging modalities, interventional radiology and radionuclide therapies used today, and the contrast in their availability around the world. The report focuses on the gap between high, middle, and low-income countries, especially in terms of resources, health system coordination, and education and training. Other topics such as the integration of imaging with other aspects of cancer care, health system strengthening, system capacity, radiology infrastructure, and potential financing solutions are also explored with the aim of providing a comprehensive call to action to improve access to cancer imaging worldwide. Medical imaging is often a topic neglected in global oncology guidelines, but one which is crucial in cancer care. Imaging plays a key role throughout the cancer care continuum, including in treatment planning, tumor staging and targeting, and monitoring tumor response, and in follow-up and detection of relapse. So why Lancet Oncology? The Lancet Oncology was launched 20 years ago with a mission to bridge the divide between science and clinical practice, and to address the enormous global burden of cancer. Since 2011, the Lancet Oncology Commissions have been instrumental in bringing together a diverse group of stakeholders including physicians and non-governmental organizations, UN agencies, and other stakeholders, providing a neutral ground for exchange of ideas and to propose solutions to improve cancer care. In 2015, the Lancet Oncology published the results of 2 commissions that assessed the gaps in access to cancer surgery and radiotherapy. And the results of these commissions were widely disseminated at high-level meetings of the World Health Assembly and the United Nations, among others. These commissions were followed by unanimous adoption of the Resolution on Cancer Prevention and Control, and a very, very extremely important milestone, as we know. So the process leading to the publication of this commission began in November of 2017 during the World Cancer Leaders Summit in Mexico City. The initiative came from Dr. Miriam Michael, now working at the IAEA, and was supported by Dr. David Collinridge, editor-in-chief and publisher of the Lancet Oncology. A concept note and white paper were developed, and in February 2018, the IAEA convened a meeting during the European Congress of Radiology to launch the concept and invite partners, mainly radiology, of course, and nuclear medicine professional organizations. This was the real beginning of what you're about to hear today. In July of 2018, we had our first formal commissioners meeting at the IAEA headquarters. Professor Risak was chosen as the lead commissioner, and the steering committee and secretariat were established. With her leadership, this became possible and moved forward in quite a quick manner. Additional meetings were held at the RSNA 2018 and the ECR, SNMMI, EANM, and RSNA in 2019. The commission consisted of 27 leading nuclear medicine, diagnostic imaging, oncology, and radiation oncology professional organizations, as well as the IAEA and the World Health Organization. The availability of trustworthy data is essential for evaluating the introduction of health technologies or for prioritizing investments. On the one hand, reference data must be taken into account, including epidemiological needs, demographics, area of influence to be covered, availability and accessibility to services, infrastructure, availability of the health technology and medical devices. On the other hand, consideration should also be given to the level of care and clinical guidelines. All data needs to be analyzed, and gaps and needs should be defined. This, of course, in combination with budgetary and human resources assessment, and all these help establish our priorities. We also considered data from other databases, like the data from World Bank. Also, data from the IAEA procurement costs of recent years and the install base equipment specifics, the age and renewal were all taken into consideration. We also linked with epidemiology, like GlobalCan, estimates of incidence and mortality worldwide for 185 countries. Viewing the imaging world through this prism for the first time led to a landmark article, which included IAEA co-authors, and this article preceded and set the stage for the final report of the Commission. So what is our scope? So the scope was to collect data and map global imaging landscape, to correlate with other data and guidelines, to showcase scientific evidence in a novel way by quantifying the global needs and modeling the impact of scaling up imaging. And, of course, to devise long-term actions and targets or recommendations. And our data can now serve to inform universal health coverage decisions with a particular focus on low and middle income countries. So we hope that, or we aim to spread the information to effect change. The Commission findings were discussed in many different areas and places, including a UN General Assembly side event, the World Health Summit, and more, and now at London Global Cancer Week. And our Director General was quite essential in producing a medical imaging and nuclear medicine universal health coverage editorial, which is also advocating for imaging. Now, if we look at what the situation is right now, we see that, unfortunately, in the past, medical imaging and nuclear medicine was not routinely included within the essential medicines and technologies lists. However, when we look at the situation now, we see that there's been progress. Some of the efforts supported by IAEA, led by WHO, to include radiology, imaging, and nuclear medicine applications and devices into the WHO list of priority medical devices. We worked together extensively on this, and this was the beginning, and now there are many other opportunities where we collaborate to move things forward in this direction. The Lancet Oncology Commission on Medical Imaging and Nuclear Medicine was a major effort initiated by the IAEA that gathered more than 50 experts from all over the world, including general commissioners, individual contributors, that worked together towards the goal to address global inequalities in cancer care. And the Commission also had the support of 27 professional organizations of radiology, nuclear medicine, medical oncology, and radiation oncology, as well as WHO and UICC, and had essential, of course, participation of the IAEA. The aim of the Commission was to provide data and guidance to act as a catalyst for sustainable change in medical imaging and nuclear medicine for cancer management. Now, to achieve this, we needed to compile global data on the availability of equipment and human resources, focusing on low and middle income countries, and to develop a microsimulation model to estimate cancer mortality that can be averted by upscaling imaging in combination with treatment. This model will be presented later by Dr. Rifat Atoun, one of the 3 lead commissioners, along with Professor Risak and myself. The third was to prepare an investment case, and the fourth was to outline actions toward realizing the health and economic benefits of upscaling medical imaging and nuclear medicine to reduce the global burden of cancer. The main source of data was the IAEA Medical Imaging and Nuclear Medicine Global Resources Database called IMAGINE, which compiles data on the availability of human resources and equipment. Over 60% of the data included in IMAGINE came from IAEA sources, and we also started compilation of nuclear medicine-related data in 2006 and radiology data in 2014. The remaining 40% was extracted from other organizations such as WHO, COSIR, OECD, and professional organizations, as well as extensive reviews of the literature. Measuring the number of scanning machines in a given place does not constitute an outcome in itself. This data has to be combined with demographic and epidemiological data compiled and managed by organizations such as the International Agency for Research on Cancer of the World Health Organization, and with evidence-based guidelines. IMAGINE illustrates the astonishing difference in the availability of this equipment and human resources worldwide. This information will be presented by Professor Andrew Scott, a member of the Commission's steering committee. So if we look at the per million inhabitants, for example, and we look at PET-CT specifically, we will notice that there is a significant inequality, and it's more pronounced for PET-CTs than other areas. For example, over 100 countries have functional PETs, but fewer than 1% are in low-income countries. This can affect management of cancer, of course, but we also need to look at other areas that require attention. So we know that cancer, of course, remains one of the leading causes of death and one of the most critical health problems worldwide. And in addition, it's projected that in the next 20 years, the global incidence of cancer will increase by up to 60%. Yet the differences in cancer mortality and access to care between different parts of the world are huge. Not surprisingly, when we look at the global cancer numbers, we see that 80% of disability-adjusted life years lost to cancer are in low and middle-income countries. But these countries only receive 5% of funding. So now there are many individuals attempting to help low and middle income countries, and we know giving of their time, of their funds, but we need a global strategy to scale up access to diagnostic imaging and nuclear medicine to support management of cancer patients. So why did the IAEA start and support this process? Well, within our commitment to transferring nuclear technologies for peaceful uses, our role in the Division of Human Health is to support member states in integrating radiation medicine, which includes, of course, radiology and nuclear medicine, and integrating these into their national development plans and strengthening their capabilities to address their health needs through the application of these techniques within a context, of course, of safe and quality clinical practice. So at the IAEA, we can say that the data-driven body of work is immediately applicable in dialogues of all of these projects that we have worldwide in 120 countries. We also help implement this in our CPFs and in supporting national cancer control plans of countries. Here's a glimpse of the global support provided by the IAEA in clinical nuclear medicine and radiology. Currently, we have 189 active projects aiming at establishing or strengthening nuclear medicine and radiology in 89 countries or territories. These projects are implemented and have allowed thousands of professionals to participate in training courses organized by the IAEA and have carried out scholarship programs supported by the IAEA as well. In 2020 alone, we invested more than 51 million euros in purchasing medical equipment, including SPECT-CT, X-ray units, and CT scanners. Every year, we support thousands of professionals from low and middle income countries to access the main international conferences organized by professional organizations such as the American Society of Nuclear Cardiology, the European Association of Nuclear Medicine, the European Society of Radiology, and the Society of Nuclear Medicine and Molecular Imaging. With all of these, the IAEA has practical arrangements to strengthen nuclear medicine and radiology and expand educational opportunities. In addition to these products and projects, we have e-learning resources that can be used regardless of the country project that's available. It's open to everyone. We get page hits from 205 countries or territories, and an average of about 175,000 users have used it. And through this website, we have complete curricula, webinars, online training, interactive modules, videos, apps, many other opportunities. Other examples of educational resources is the CELF platform, which basically goes from consultation throughout the different steps of management of patients, including all the way to treatment and quality assurance, but it also covers things like mammograms, SOPs, how to read PET-CTs, and so forth. This is a work in progress, and it's quite interesting because it emulates a apprenticeship of a physician, and is very helpful, especially in areas that do not have multiple physicians available for easy consultation. Large symposia are helpful because they allow a large number of countries to be involved. In this case, for example, the last IPET one had 3,000 participants from 126 countries. Participants are supported to come to Vienna to attend this as well. Tumor boards are important as well and include a diagnostic imaging component and cover many regions. Guidance and publications are something that are essential for our purposes, whether it's curricula, health series on specific subjects or other. And then we work with several global initiatives. This is an example of the UN Joint Program for Cervical Cancer Prevention and Control that included multiple UN agencies that were able to work together in specific countries to support the management of cervical cancer. And in this particular situation, IAA supports radiotherapy and diagnostic imaging. Research is another way we can contribute, and as you can see, we have many countries, 102 countries that participate in these projects that vary from clinical trials, patterns of care, assessing educational interventions, and so forth. These projects are not just research projects, they also provide development assistance, for example, procurement for, let's say, QA equipment, phantoms for nuclear medicine QA and other things, education and training, especially in the specialty, doctoral CRPs, training in specific techniques like cardiac amyloidosis or PET-CT and atherosclerosis will include training. And then research workforce training to allow this capability to be developed in member states who don't have a significant access to research. But also we look at health systems and implementation research. An example is through INCAPS and others, where we can guide the planning at the policy and country level through an economic guidance through this research. Then we do resource-sparing research. Examples are PET-CT, how often we do PET-CT after, let's say, lymphoma in pediatric or adults, and so forth, and we have many in radiotherapy. There's also direct country involvement in these, so it directly benefits the country on the ground. Safety is another area that is extremely important, whether through education training, staffing levels with guidelines, or project planning, radiation safety through education training, specifically in radiation safety, and support for radiation safety infrastructure, reporting of accidents, quality assurance procedures, choosing appropriate equipment that's essential for good safety and quality. So now back to our Lancet Oncology Commission. We know this was the first comprehensive global data collection on imaging and nuclear medicine, and the first evidence demonstrating on a large scale the substantial health benefits from scaling up imaging and nuclear medicine access for cancer patients. A compelling economic case for investment was made, and also a call to action with 6 specific action points we'll hear about. So we are here to empower member states with data like Imagine that can be accessed globally to inform this planning and maximize success. Without data, we will fail, and the presence of data is essential. The Commission report scope spelled out this compelling evidence of substantial benefits, and we hope that it will lead to significant change. But now we have the tools, and we can deliver better outcomes for patients if we can use the tools, the economic information that was generated and the data to support imaging worldwide. The Lancet Oncology Commission on Medical Imaging and Nuclear Medicine was a major effort initiated by the IAEA that gathered more than 50 experts from all over the world, including the general commissioners and the individual contributors that worked together to address these global inequalities, as mentioned before. The 27 professional organizations, through radiology, nuclear medicine, medical oncology, and radiation oncology, and others have supported this effort. It was a truly comprehensive effort that included all different groups interested in seeing radiology move forward. Thank you very much.
My name is Andrew Scott, and I'll be presenting on global utilisation of imaging and nuclear medicine in oncology. And I have no declarations to report. When addressing the information on both imaging equipment and workforce at a global level, using the Imagine database as outlined in the prior talk by my colleague, Professor May Abdel-Wahab, we use the World Bank country income classifications to be able to categorise individual countries according to income for all of this imaging and workforce data. As per the World Bank, the low-income country definition is a gross national income per capita of less than $1,045 per year, which results in 9% of the world's population being encompassed within low-income country groups. Middle-income countries can be defined according to lower middle income and upper middle income. In the lower middle income countries, the income per capita is between $1,045 and $4,095 per year, and upper middle income countries earn between $4,095 and $12,695 per capita per year. Middle income countries represent 75% of the world's population. And high income countries, which is 16% of the world's population, have a gross national income per capita each year of greater than $12,696. When applying these country income classifications to the Imagine database, we were able to define the numbers of scanners for equipment per million population according to each of the country income groups. These are listed in this table for CT, MRI, SPECT and PET according to the different income country categories. A number of very important observations came out of this very extensive information gathering exercise of up to 200 countries around the world. The first was that there were substantial differences found in the number of scanners per million population between each of the income group categories, as well as within each of the income group categories. So, for example, for CT, you'll see that in high-income countries, the median number of scanners per million population is 20.5, with an interquartile range between 14.4 and 32.7. When then going to upper middle-income countries, the median goes down to 7.8 scanners per million population, with an interquartile range between 4.8 and 16.2, and then down to 1.4 in lower middle income countries for a median number of scanners per million population, and then to 0.4 for low income countries. Similar trends were seen for MRI, where in high income countries the median number of MRI scanners per million population is 12.6, with an interquartile range from 8.5 to 19.2, but going up to 34.3 in one country. Upper middle income countries, the median went down to 3.4, lower middle income countries down to 0.4, and in low income countries down to 0.1 scanners per million population, with many countries having no scanners at all. For SPECT, Similar trends, but smaller numbers. In high-income countries, 5.4 scanners per million population, ranging from 2.4 to 9.7. Upper middle-income countries, it went down quite substantially to 0.9 scanners per million population, with a number of countries in the middle-income range having no SPECT scanners at all, a median value of 0.1 in low middle-income countries, and none at all in low-income countries. PET, which has increasing use in staging, restaging, and treatment response in cancer patients, had a median number of 1.2 scanners per million population in high-income countries, ranging from 0.6 to 2.5, with a maximum of 4.3 per million population, which is quite low compared to SPECT, MRI, and CT. In upper middle-income countries, the median number of scanners went down to 0.2, and then down to 0, the median, for low middle-income countries and low-income countries. So quite clearly there's quite marked variation depending on the income level of the country, but also within each of these country income categories. And this data does allow estimates for projected equipment requirements for cancer care to be determined, so that in, for example, middle-income countries to be able to have the same numbers of, for example, median per million population of a high-income country group would be an area where investment could lead to increased access and availability. This is depicted graphically here, looking at a world map. You can see the number of CT scanners per million population. Dark green is greater than 30, and the green shades are essentially from greater than 10 CT scanners per million population. Very high numbers of CT scanners in high-income countries, particularly in Europe, the US, Alaska, in Asia, in Korea, Japan, Australia, and even in Argentina. Whereas very low numbers, ranging from 0 up to less than 10 CT scanners per million population, quite significantly throughout Africa and extensively throughout Asia, and also areas of Latin America as well. MRI scanners, the trend is even more marked, where the greater number of MRI units, depicted by the darker shades of green, being within North America, throughout Western Europe, Korea, Japan, and Australia, and very low numbers being present within countries within Latin America, although Brazil does have reasonable numbers of MRI scanners, extensive reduction in the availability of MRI throughout Africa, Middle East, and through into Asia as well. For SPECT, looking at the higher numbers in the darker shades of green throughout North America, again, Brazil, Argentina, reasonable numbers throughout Europe, and also Korea, Japan, Australia, but extensive areas of Africa and throughout Asia have very poor access to SPECT scanners, mainly used for bone scanning in patients with cancer. And for PET scanners, even more marked. You can see that the higher numbers are principally in North America, Europe, Korea, Japan, Australia again, but extensively throughout Latin America, throughout Europe, and also Asia, particularly Eastern Europe, and throughout Africa, many countries that have absolutely no access at all. When looking at workforce, we explored both for radiologists and for nuclear medicine physicians the numbers of credentials experienced clinicians working in these areas according to income group numbers. Now you can see for radiologists, and this is depicted also in the world map you see on the right side of the slide, a median of 93 radiologists per million population exists in high-income countries, which has a range up to 194 per million population. Of course, these specialists will work not just in oncology areas, but also in many other areas of medical imaging diagnosis. But it does indicate the availability of experts who work in this field. And you can see for radiologists, mainly again in North America, throughout Europe, and numbers between 50 to 100 are also in Latin America, for example, Brazil, Argentina, China, Korea, Japan, Australia, and also New Zealand. Median numbers going down to 30.6 in upper middle income countries, down to 6.9 in lower middle income countries, and only 1 per million population. So almost 100-fold difference between low income countries and high income countries. Nuclear medicine physicians had similar trends. Smaller numbers. We also know that in some countries, nuclear medicine studies are reported by radiologists. In many countries, nuclear medicine studies are reported principally by nuclear medicine physicians. But a median of 6.5 per million population in high-income countries, but going down to 1.5 in upper middle income and down to 0.1 and none at all in low middle income and low income countries. Again, North America, particularly Western Europe, going through to Japan, Malaysia, Australia, have reasonable numbers, certainly greater than 5 to 10 per million population, but extensively throughout Latin America, Africa, and throughout Asia, very few nuclear medicine physicians work in these countries. So as mentioned, there's clear gaps that have been identified, both in terms of imaging equipment as well as in workforce, and that in low and middle income countries, there's substantial reduction in the availability of imaging equipment, without which, of course, imaging in cancer patients cannot be performed. For nuclear medicine studies, radiopharmaceutical access is also a key factor which impacts on availability of nuclear medicine imaging procedures. And we know, as example, through the COVID restrictions on supply chains, that the radiopharmaceutical access to many countries can be substantially impacted by changes in transportation. And so this is an area of particular focus in low middle income countries to ensure there is continued access of these imaging probes to be used for nuclear medicine studies. As mentioned, equipment availability can be quite varied even in similar income country groups. And a trained workforce, and it's not just in the interpretation of the scans with radiologists and nuclear medicine physicians, but also our radiographers, our nuclear medicine technologists, medical physicists, radiopharmaceutical scientists are essential for the delivery of these imaging services. And if we don't have them available, the studies can't be performed, and the quality of the imaging studies performed can also be impacted. A key point that was found is that there is a lack of country policy guidelines on the appropriate levels of imaging and nuclear medicine facilities and workforce that are required for the care of cancer patients. And so this commission felt that this was a key area for action, which will be discussed later on during this session. The other very important point is that training programs and online resources were reported to play a vital role in workforce education, particularly in low and middle income countries, and clearly is an area of focus for the future. Technology advances were identified as one of the ways in which increased access and availability of imaging can be made available to cancer patients. The first being digital connectivity, both for patient-related information, and this can be both for referrals as well as for the bringing together of all the relevant patient investigations and clinical history in an electronic medical record. EMR implementation is variable in both high and middle income countries, but particularly in low income countries is only implemented in very small numbers. One estimate is that only 15% of low income countries actually have electronic medical record implementation in a comprehensive way, even starting to be implemented. So clearly this is a focus which can impact on cancer care and also on the appropriate use of imaging in these patients. Low-cost mobile point-of-care devices clearly are having an impact. And the example you see on the right-hand side of this slide is of an ultrasound transducer which can actually be linked to a mobile phone to generate imaging data which can be used for diagnosis, as well as for distribution for reporting at distant sites. And it's not just these transducer technologies, but we know that new solid-state systems, modified gantries for CT, MRI, SPECT and PET are being developed. and these can then be utilised for cost-effective mobile scanner approaches. Artificial intelligence has received considerable attention to its ability to impact on imaging over the last few years. This can be also extended to when patients begin their journey for imaging. And this is an example you see here of a workflow that can be utilised with digital recognition of patients, the use of standardised protocols which can be modified based on the referral information, as well as biosensors which can pick up characteristics of the patients which can guide certain protocols which can be used for imaging studies in these patients. In particular, the processing of the imaging data which is obtained with different algorithms so that you can have improved image quality and also automated or semi-automated extraction of information which can be used to inform the actual reports which are generated. This is an area of considerable excitement moving forward, so that you will be able to get improved image quality and also information from the acquired images, which can then be brought to the radiologist or nuclear medicine physician for final review and interpretation. This can then be distributed through digital technology to the referring physician or to the multidisciplinary teams that are involved with the care of cancer patients to enable appropriate management decisions to be made. So it's this implementation of AI which has great potential, not just in high-income countries, but also in low and middle-income countries, to improve the quality and the interpretation of images, even if experts aren't always physically available at the site where the study is performed. Teaching, training and research is critical to any aspect of medical care. And one of the things that was clearly demonstrated through the data which was obtained as part of this commission was the importance of ensuring that workforce training and technologies, because of the changes which are occurring so rapidly in many areas of imaging technology, can be sustained and can be implemented at a broader country-based level. We also know that the generation of evidence for new imaging technologies is very important in order to gain both regulatory and funding approvals. And increasingly the use of clinical trials, not just industry sponsored, but also academic investigator-initiated studies, often through cooperative groups, can be very important as well. And we believe that the training of younger clinicians and the technologists and scientists working in the imaging space in low and middle income countries can enhance their ability to undertake involvement with clinical trials, increase their quality activities, and also gain greater participation in some of the imaging trials which are essential to gain greater experience and also evidence for implementation. A number of programs, particularly through the International Atomic Energy Agency, have been initiated to promote this, and online learning through many of the professional bodies in the radiology and the nuclear medicine space, such as ESR, RSNA, as well as EANM and SNMMI, are becoming more important in ensuring that our colleagues in low, middle and high income countries can be aware of the latest advances and approaches to imaging technology. It's very clear that major institutions play a key role in the training and the teaching of our professionals, as well as for research. An example of that is in theranostics, where huge advances over the last few years, such as in the treatment of neuroendocrine tumour patients with lutetium-177 somatostatin analogues, or such as Lutathera, or more recently, lutetium-177 PSMA is having enormous impacts in prostate cancer patients, as evidenced by the therapy and the vision trials. So being able to perform these imaging-based studies that can lead into improved therapy and generating evidence which can be used for healthcare policy consideration and implementation is key. Thank you for your attention.
Warm greetings from Boston, USA. I'm Dr. Rifadatun. I'm Professor of Global Health Systems at Harvard University. It's a real pleasure to contribute to the London Global Cancer Week. I'm going to share with you the findings of the Lancet Oncology Commission on Medical Imaging and Nuclear Medicine, specifically the analysis of global costs, health benefits, and economic benefits of the scale-up of cancer imaging, along with treatment modalities and quality of care. But first, some antecedents. In 2010, with my colleagues Paul Farmer, Julio Frank, and Felicia Chenol, and many others who were members of the Global Task Force on Expanding Cancer Care and Control, we identified a huge need for expanding cancer care and control in low and middle income countries. We identified in this paper published in the Lancet that while 80% of cancer burden was in low and middle income countries, just 5% of funding was allocated to these countries. So there was a huge divide and huge inequities. So we called for an expansion of cancer care and control, and in this paper issued a call to action. Since then, we've been able to develop an investment case for demonstrating the benefits of scaling up different interventions at global level to address the cancer challenge that we identified. An investment case for cancer is essentially an organizing principle for a core set of actions. It emphasizes not just costs, but health and economic benefits. It changes the narrative from cost to return, and it provides a clear time horizon for the actions and interventions, the costs of scale-up, and the returns that can be realized in terms of health benefits, also in terms of economic benefits. And we have, since 2000, we've developed a number of investment cases, starting first with the Lancet Oncology Commission on Expanding Global Access to Radiotherapy, when we demonstrated very large benefits to the scale-up of radiotherapy, contrary to popular belief. And then more recently, the Lancet Oncology Commission on Sustainable Care for Children with Cancer, where we're able to demonstrate that for every dollar invested, there would be $3 of return for when expanding cancer care and control for children. And most recently, in the Lancet Oncology Commission on Medical Imaging and Nuclear Medicine, we extended this work using a simulation model. So in this paper, in a series of papers that fed into the Lancet Oncology Commission, and I'd like to acknowledge the outstanding work of my colleague and team member, Dr. Zachary Ward, we estimated the impact of treatment and imaging modalities and on 5-year net survival, on aversion of deaths, and also the economic benefits. To do this, we developed a microsimulation model of stage-specific cancer survival in 200 countries and territories for 11 common cancers. We then estimated the country-specific availability for chemotherapy, surgery, radiotherapy, targeted therapy, and imaging modalities ranging from ultrasound to X-ray to CT, MRI, PET, and single photon emission CT, as well as quality of care. Then we calibrated the model to reported 5-year net survival estimates from Concord 3 study to 2020 to 2050. We then estimated costs and the survival gains, as well as deaths averted by the scale-up of individual treatment and imaging modalities, and also these different combination of these interventions to the mean level of high-income countries. We then computed the economic benefits of the scale-up with different scenarios, and the benefits on improving in cancer survival and reduction in deaths. We then compared the cost of scale-up with the economic benefits to estimate the returns with scale-up of cancer diagnosis, treatment, and care compared with no scale-up. So let me share with you the findings from these analyses. First of all, with 5-year net survival, there's an increase as one scales up different interventions, for example, compared to baseline, and these results are shown by country income groups. Improving quality of care leads to improvements in 5-year survival in low-income and lower middle-income countries, in fact, in all countries. But one begins to get higher returns when quality of care is combined with treatment, traditional treatment, and higher gains when imaging is added to this, and then when when more advanced imaging, for example, CT is added to the imaging modalities, traditional imaging modalities. And finally, most of the gains are realized when there's comprehensive scale-up of quality of care, treatment in terms of surgery, radiotherapy, chemotherapy, traditional plus advanced imaging, and targeted therapy. And as you can see, the benefits are realized most in low-income countries and lower middle-income countries. And the deaths averted and the life years saved globally by different scale-up scenarios are very large. With scale-up of imaging, the number of cancer deaths averted amount to $2.5 million, around 2.5 million deaths, accounting for about 3.2% of total global deaths, with projected number of life years saved amounting to 33 million. With treatment alone, the number of cancer deaths averted reaches 4.1 million, accounting for 5.4% of total global deaths in this period of time. And this amounts to 58.4 million life years saved. But with comprehensive scale-up that combines imaging, treatment, and quality of care, the gains are the largest, and we see synergistic effect. The number of cancer deaths averted amount to 9.6 million, accounting for 12.5% of global deaths, with the projected number of life years saved amounting to 133.7 million life years, with a discount rate of 3% per year. So the benefits in terms of deaths averted and life years saved are very, very substantial. But we see a very interesting phenomenon. So in low income and lower, well, in all countries we see an increase in terms of cancer deaths averted with scale-up, with comprehensive scale-up. But in low-income countries, whereas in high-income, upper middle-income, and lower middle-income countries, the increases are more linear. With low-income countries, we see an inflection at 40%, 60%, and particularly at 80% scale-up. So with comprehensive scale-up, low-income countries benefit far larger when scale-up reaches 80% of current levels. So that's a very important message for policymakers and those investing in health systems to scale up cancer care and control. Similarly, the net benefits are enjoyed by all country income groups. In high-income, upper middle-income, and lower middle-income countries, the increases are linear, whereas in low-income countries, with comprehensive scale-up, as we reach 60 to 80%, we see a sharp increase in the net benefits realized. If we look at cumulative net benefits, we see the importance of combining the scale-up of imaging, treatment, and quality of care into a comprehensive set of interventions. If you look at the cumulative net benefits in 2020 to 2050, and the net benefit on the y-axis differs for each country income group. For high-income countries, the benefits of scaling up one or the other intervention in isolation is not very, very different, partly because in high-income countries, most of the imaging modalities have been scaled up, as has been treatment and quality of care. Whereas with upper middle income countries, we see compared to a baseline, we begin to see synergistic benefits of combining imaging, treatment, and quality of care into a comprehensive set of interventions. We see far larger benefits in middle lower income countries compared to baseline when comprehensive care is scaled up. But the largest benefits are realized in low-income countries. And as we can see here, compared to baseline, there is benefit in scaling up imaging. There's also benefit in increasing treatment and quality of care. But the largest benefit comes by increasing comprehensive set of interventions. And in all country income groups, the benefits are realized fairly quickly. As you can see, we begin to get into positive net benefit territory by 2025 for all income country groups. So this is a very important message that there's a myth that scale-up of cancer diagnosis or diagnostics for cancer treatment and care is very expensive, but the net returns are realized fairly early on. And the lifetime cost and returns are very interesting, because the incremental cost in the period 2020 to 2030 with comprehensive scale-up is $232 billion in the 200 countries and territories, which is not a very large amount, given that this is over 10 years and across 200 countries. This amounts to 6.9% increase in the current cost of care for cancer. But the lifetime productivity gains are staggering. They amount to $2.89 trillion. When we subtract incremental cost from the lifetime productivity gains, because individuals who live longer and whose deaths have been averted, going back to the workforce and contributing to economy, leads to very large productivity gains. And the net economic benefits in the period 2020 to 2030 with comprehensive scale-up is $2.66 trillion. So for every dollar invested, there's a return of $12.43 with comprehensive scale-up. Scaling up just treatment and quality yields a return on investment of $6.5 for each dollar invested. Here we see the importance of scaling up with diagnostics, where the returns are far, far larger compared to just increasing treatment or just increasing quality of care. And if we look at the returns by country, and this is a sort of heat map of the potential returns per US dollar invested, all countries benefit. And we see there's substantial gains in Latin America, as well as in Southeast Asia and many African countries, as well as some of the Southern European countries. So for the first time in the study, we've been able to demonstrate or estimate the cost of the scale-up of imaging diagnostics, along with different modalities of imaging diagnostics, along with treatment, namely surgery, radiotherapy, and chemotherapy, plus quality of care, to show very large returns to investment and very substantial gains in terms of life years saved, but also in terms of deaths averted. So the Commission provides a very important message to policymakers to think about not just cost of a scale-up, but the returns that can be harnessed in terms of reduction in deaths, in terms of improvements in quality of life and number of life years saved by increasing survival, and as well as health gains, very, very substantial economic gains. So there's no reason for not to invest in the scale-up of cancer care and control with imaging diagnostics. Thank you very much for your attention.
Dear friends, dear colleagues, it is such an honor to speak at the London Global Cancer Week, and on behalf of our entire team, I would like to say how very much we appreciate this opportunity to share the results of the Lancet Oncology Commission on Medical Imaging and Nuclear Medicine. Our sincere thank you to Dr. David Collingridge for giving us the opportunity. My task is to present an overview of the Commission findings and recommendations. Before I begin, my disclosures are as follows. I serve on the Board of Directors of IBA, External Advisory Board for the Johns Hopkins Cancer Center, International Advisory Board, University of Vienna. I also serve on both Scientific Committee and Board of Trustees for the German Cancer Center. The question is really, why now? Why is there growing concern about global cancer burden? Well, Internet access to global data is at our fingertips, and we all are much better informed. We all are greatly concerned that between 2012 and 2018, the new cancer cases worldwide grew by more than 28%. And we are so much aware that there are dramatic worldwide inequalities in access to cancer care with wide disparities in survival. Unfortunately, the gap is widening. Differences in survival are growing, as in low middle-income countries, there continue to be delays in diagnosis and staging. Access to cancer care is limited, and we have to admit there is little or no access to the latest treatment option. I think we all are very touched by the statement that cancer has reached global pandemic proportion, and in the low middle-income country, cancer mortality is surpassing the global mortality from HIV, AIDS, malaria, and tuberculosis combined. And that is so evident as we look at the world's map on cancer survival. This is estimated 5-year net cancer survival for breast cancer. The month of October was Breast Cancer Awareness Month. In the United States, Western Europe, Australia, Japan, South Korea, or Saudi Arabia, the 5-year net cancer survival for breast cancer is in high 90s, above 95%. But that certainly is not the case in the major parts of the world. There are too many colors. The scale from green to very dark red and maroon is painful to observe. And especially countries that have been in the war and are in the war continuously, such as Afghanistan, Yemen, Sub-Sahara region, and other large parts of Africa. There is really almost no chance of survival from breast cancer. Very similar picture is seen as we look at estimated 5-year net cancer survival for prostate cancer. The latest data show that when detected early, the estimated 5-year cancer survival from prostate cancer, which month of November is the awareness of prostate cancer, is 98%. But if you live in part of Asia, India, Pakistan, Afghanistan, that is very, very different, as is, once again, in the major part of Africa. And then colon cancer, 5-year survival for colon cancer does need improvement, and we are all aware of the importance of screening and early detection. Western countries such as United States, Australia, parts of Europe, as well as Saudi Arabia, are in about high 60s, low 70%. But even in Europe, that is not the case. Look at the heterogeneous colors. Survival between Germany and Scandinavian countries, and even England, it is too yellow, and it does need improvement. And we need to ask ourselves, can we continue to witness that one's postal code and not one's genetic code determines one's survival? Can we really continue to witness that 80% disability-adjusted life years lost to cancer are in low-middle-income country, yet that area receives only 5% of global funding for cancer control and care? Over the years, there have been a number of attempts to improve cancer survival in the middle and low middle-income countries. But really, there is no clear, overarching global strategy for scaling up cancer imaging diagnostics across low middle-income countries. And this is why we are so grateful that the Lancet Oncology decided to look at the need for medical imaging and nuclear medicine. This was a large, multidisciplinary teamwork between authors, commissioners, and individual contributors. And we came from all over the world. We came from all disciplines that deal as a cancer team: surgery, medical oncology, radiology, radiation oncology, as well as medical physics. This is the list of our authors, and from all of us, once again, sincere thank you for giving us the opportunity. Our Lancet Commission was not supported by industry. Rather, it was supported by societies, institutes, organizations, and foundations. It was supported by medical organizations such as ASCO, ESMO, radiation oncology such as ASTRO and ESTRO, as well by a number of societies that deal with diagnostic imaging such as RSNA or ACR, and those with nuclear medicine. A very special thank you goes to the International Atomic Energy Agency. They were absolutely spectacular, and without their involvement, much of the data that I'll present would not have been possible. So as we look at the efforts, we aligned our mission with the 2017 WHO Cancer Resolution, cancer prevention and control in the context of an integrated approach with the shared goals to increase access to affordable, safe, and effective diagnostics for cancer care. And wholeheartedly, we support UN health targets for 2030 Agenda for Sustainable Development. We are really proud of our achievements, as for the very first time we have shown comprehensive global data collection on imaging and nuclear medicine equipment and workforce. Thank you to IAEA Imaging Database. Without a baseline, you really don't know and cannot develop metrics to improve. For the first time, we demonstrated the substantial health benefits of scaling up imaging and nuclear medicine access for cancer patients globally, and thanks to Professor Atun Rifat, compelling economic case for further investment in imaging and nuclear medicine. Thanks to Professor Rifat and his postdoctoral fellow, Zach Ward, we really showed the health benefits of scaling up imaging and nuclear medicine for 11 most common cancer between 2020 and 2030. If we do nothing, projected worldwide cancer death will be 76 million. If we scale up treatment and quality of care, we can decrease or avert about 5.4 million deaths due to cancer. But if we add imaging to treatment and quality of care, the number improves to 9.5 million. That difference, of course, is not the same around the world. Expansion of treatment, imaging modality, and quality of care will have different impact in economically different countries. We can improve a 5-year survival in low-income countries from 3.8% to 45.2%, more than 10 times. The number is still very impressive, but it is lower for the lower middle-income country, where improvement in survival goes from 20.1 to 47%. And what is so amazing, that the largest yield for the cancer survival and improvement actually comes from ultrasound, incorporating just simple ultrasound and X-rays. So looking at the ultrasound in the low middle income country, we really need to benefit from device engineering, which is new, relatively inexpensive. We have to understand that smartphones are widely available, and there already is a new class of low-cost mobile health portable devices with ultrasound. They connect directly to the smartphones or the tablets, and they can be through teleradiology and telemedicine distributed for expert opinion around the world. Clinical applications of such a simple device are many. For diagnosis and biopsy, we can examine thyroid gland, liver, breast, peritoneal cavity, kidneys, in the pelvis, uterus, ovary, or prostate. We can even perform treatment such as tumor ablation for liver and kidney. We can really make the difference. And device cannot be more simple. But in order to implement, we have to teach, we have to educate. But having education, such as this workshop in Nigeria, you need radiologists and you need experts. Yet, when we look at estimated number of radiologists per million inhabitants, the data provided by IAEA Imaging Database, then we see we do have a relatively large number of radiologists in the United States and parts of Europe. But even in Europe, the number of radiologists are not evenly distributed. And being in London, I'm sure you are looking at England and maybe having a hard time believing. There is, and we all know that, we simply don't have enough radiologists. But the picture is much more grave when we look at Africa and look at countries that they have less than 10 radiologists per million inhabitants. You know that any change will be very difficult to implement. It's almost worse when we look at the estimate nuclear medicine physicians. And I know your eyes are going to England because it's really difficult to believe that the number of nuclear medicine physicians per million actually is very similar to some of the low, middle, and middle-income countries. So we do need a reform that's not only for low-middle country, but every single country needs to look at the data and develop a 5-year plan. It is very puzzling that when we look at nuclear medicine physicians per million people, such a big difference between Norway, Sweden, and Finland, or between Germany and France. There's so much that we should and we need to do and plan. You need people, but also you need scanners. And once again, far too uneven distribution of CT scanners around the world. It's not surprising that countries that not only are low middle-income countries, but are continuously harmed by war, such as Afghanistan, such as Yemen, and even Pakistan is really not doing too well. So we need for each region and each country a separate plan. And yes, we do know that number of CT scanners in England is insufficient. The same goes for the MRI scanners, such a similar picture around the world and such a push and compelling evidence that we should and we can change. PET scanning is an ABC in oncology care in the developed countries. But even in the developed countries, the estimate number of PET scanners per million inhabitants is simply too heterogeneous. So what are the next steps? Well, there are certain recommendations for policy and investment, and while we specifically concentrated on low middle-income countries, I think they apply to each and every of us. Imaging diagnostics must be part of essential benefits package when expanding universal health coverage. National cancer control plans must include actions for scale-up of cancer imaging diagnostics, including both imaging equipment and workforce. We have to develop workforce through investment in education and training. And today, with internet connection, it's easier than ever to foster collaborative networks of imaging diagnostics across the world. We have to invest in R&D to foster innovations in so many levels, but especially for low middle-income country, it's really development of affordable cancer imaging diagnostics. And we do have to increase capacity of imaging equipment and workforce in the low middle-income countries. As we present those data, there are many health economists, and everybody says, how about return on investment? Investment in a comprehensive scale-up of treatment, imaging, and quality and care does yield positive results. For every dollar invested, Return on the investment, if you scale up only treatment and quality of care, is $6.15. But when you add imaging, and there is a comprehensive approach to improving cancer care, then that in return on investment doubles. And potential for the low middle income country finance source. There is a domestic source, public financing and complementary funding from private sector, development banks. We are so lucky to have so many development banks that really want to help. And this is our opportunity to present a comprehensive, data-driven plan. Pre-COVID models suggest that 5% growth of GDP annually is seen in most low-middle-income countries. We can benefit from that. And then source of increased income, reprioritization of health care within government budget, and why not, increased tax efficiency, taxes such as tobacco and alcohol. We are only at the beginning in fighting tobacco and smoking. Just look at the map for the 5-year net cancer survival for lung cancer. It is far too red. It is red all around the world. So now the hard work begins: dissemination, advocacy, and implementation. We need to ensure that Commission findings are disseminated and implemented. This is why we are so grateful to this forum, to giving us an opportunity to present. And as we move forward, we need to address all stakeholders that can help in taking action: government, funding agency, international agency, professional association, health professionals. Each and every of us can make a difference. Researchers, innovators, and then private sector and civil societies. We do remember, let us be inclusive, persistent, and as a healthcare force, stay united. Cancer care is a team effort. And thank you, so very much thank you, for being the change that we need. Thank you very much.
Thank you very much to all 4 of our speakers for your excellent and very informative presentations. It was really enjoyable to see the highlights of the findings from this very important commission. We now have some time to go to a Q&A session with our presenters. We should have 3 of our presenters online now, ready to answer your questions. Unfortunately, Professor Rifat Atun was unable to join us today as he has a prior commitment, but we do have the other 3 with us, and they are keen to answer your questions. So we don't seem to have any questions in the chat yet, so please do start to submit any questions for our presenters in the Q&A box. And in the meantime, I will start with a couple of questions that I came up with during the talks. So first of all, to Professor May Abdul-Wahab, obviously the provision of global imaging is an important part of cancer care, but what other current global cancer initiatives do you think that you need to be involved in to help ensure the success of this?
So we have, well, I mean, there are 2 parts of that question. One is, what are the global initiatives that we're supporting right now that would include diagnostic imaging and nuclear medicine? And that's really important, because whatever global initiatives are already ongoing, you really need the whole scope of cancer management, prevention, treatment, and so forth. So with that, we can start with global initiatives on cervical cancer. As you know, that we've had a lot of interest in cancer recently on the global level, and non-communicable diseases have been center in the SDGs in decreasing the SDG target, SDG 3 target 3.4, and decreasing or increasing survival by 30% by 2030. So it means that many countries around the world are recognizing the importance of addressing NCDs and how many people live longer and end up having morbidity or mortality.
Dear friends, dear colleagues, it is such an honor to speak at the London Global.
Okay, good.
About that, not sure.
Dear friends, dear colleagues, it is such an honor to speak at the London Global Cancer Week, and on behalf of our entire team, I would...
Okay. We have a little bit of a technical issue, I see. But for right now, back again. So I said that radiology, nuclear medicine, diagnostic imaging are really important to be part of these global initiatives. And the first one, we can say the cervical cancer elimination initiative, which is very exciting because of the recognition that these young women die of cancer early. And there's a huge, other than the woman herself, but there's a downstream effect on the whole society, including families and the, keeping the society intact and together. And it's something that's preventable and curable. So obviously, there's the prevention part, which is the vaccination, but also when we come to the role of imaging and diagnosis, staging, in follow-up in many other areas, it's extremely important. So we are involved in this process to make sure that imaging is represented there, and we can support countries in this process. In addition to that, we have things like the breast cancer initiative. The Global Breast Cancer Initiative is just relatively new. It's one of the newer initiatives globally that's been started. And again, we have our colleagues are involved in all the working groups to make sure that imaging, which we recognize is extremely important in breast cancer, can be supported and represented in every step of the way. And finally, we can say that we have a pediatric cancer initiative as well, very similar process. So throughout this whole cancer continuum, imaging can be part of it and can be represented through involvement of the IEA and colleagues that specialize in diagnostic imaging and nuclear medicine to provide input and support to these programs around the world. I think without that, then we would not have the complete armamentarium to be able to help our patients adequately. So that's an example of some of these global initiatives. Then there are initiatives within the IAA. One will be announced February 4th. That's a really innovative initiative. So if you join us World Cancer Day on February 4th, this will be announced. It's quite a significant one. And it includes imaging as well in multiple countries. So with that, I'll pass the baton to my other colleagues.
Thank you, May. Another question I have actually, and perhaps Professor Andrew Scott might like to take this one. Obviously, as highlighted in the Commission, there's a huge workforce gap globally between high-income countries and lower middle and lower income countries. And what do you think can be done to help resolve this?
Thanks very much, Kat. I think there are a number of ways that this can be approached, and clearly it needs to be adjusted according to country-based and regional issues. Certainly the justification for workforce is very clear on the basis of the demographic distribution of the number of radiologists and nuclear medicine physicians that we were able to demonstrate. And I think the global maps that were shown were a very insightful way to illustrate the inequities and the unmet need. Clearly at a country level there's great importance on local training initiatives, but the ability to actually have linkages of training programs between low middle income countries and high income countries can be extremely successful. The International Atomic Energy Agency can play an important role in being able to link training programs between low middle income countries and high income countries, and can actually generate a frisson of interest and also collaboration between those groups. The new technology improvements, which allow real-time distribution of images, even within countries, from rural regional areas into major capital cities, can also be utilised, I think, a lot better than has been previously. And the improved access to patient clinical information through electronic medical records is a key component of that. We know low middle income countries, only 15% of them have any form of EMRs that are routinely used. But as the technology revolution continues and connectivity improves, we will be able to see the transfer of image data sets within countries and between countries to assist with that process. The other very important point is that this is the very first time that we've been able to see such a clear and unequivocal health outcome improvement through the implementation of medical imaging and nuclear medicine. And we all know that when it comes to implementation of technologies in healthcare, if you don't have a robust case for improvement in health outcomes, then you will never get traction at a government level. But we can see that the ability over a 10-year period to scale up imaging resulting in more than double of the improvements in survival in cancer patients, in conjunction with improvements in treatment and quality of care, which is where most of the focus in cancer care is at a policy level, is very powerful. And even from an economic level, it can double the return on investment, as was shown in the presentations during the session today. So I think being armed with this information on improvements in health outcomes and return on investment will be a way governments and regions can decide to invest in the training as well as the technology that can be used for imaging.
That's great. Thank you, Andrew. And a question for Professor Rissack. When you were preparing the Commission report, were there any particularly surprising or alarming findings that you really weren't expecting? I think you're on mute, Professor Rissack. We still can't hear you, I'm afraid.
I am so glad. I was thanking you. So, can you hear me now?
Yes, you can. Thank you.
Okay. Well, I start saying that we are really grateful from our community of imaging and nuclear medicine to Lancet Oncology, to you and David, for giving us opportunity for the very first time to have a global picture of what is there and what is not there all around the world in imaging. And that includes equipment and human resource. I think without that benchmark, it's very difficult to move forward. Second, I think that it has shown, Kate, we know, especially in a tertiary cancer center, how essential imaging is. It's like a GPS. Unless you know what you have and where you go, it's very unlikely you'll get there. So now that we have a benchmark, now that we know, now the real work starts. And I think what May presented with their plans in IAEA is spectacular. And we all need to join WHO, all the organizations, and have a
really a comprehensive and structured approach. Some countries are already starting. I know Brazil is already designing what they need so they can present to their Ministry of Health. Because, we say in this country, all politics is local. Unless the people on the ground get really involved and use this data for the next step, it will be very difficult to move. You asked me what I was surprised. I was really surprised how it's not only, number one, I wasn't surprised, we really showed countries that have been in the war for a long time suffer not just the human lives, and people suffer in healthcare and in cancer. And we have really shown that Afghanistan, Syria, Yemen, it's hard, and parts of Africa. It's really difficult. So as we try to implement peace, it is so important on all levels. Second, in the countries that we think are very developed or Western, well, maybe the healthcare needs for cancer needs a little more attention. So I think this is important for everybody to look at the data and plan for better tomorrow. And thank you again.
Thank you. And have you, obviously it's been, 8 months or so since we launched the commission. Have you seen a lot of positive response or traction since then in that time frame?
Yes, and actually the very positive is, first of all, it's when people see our data in the medical field, in the cancer care, they are surprised. We showed the data at the surgical meeting, and they were just surprised. They didn't realize. So that's now number one. Now, number two, our study was not supported by industry or pharmacy or any commercial entity. But what's happening now is that the industry, a big equipment industry, is really now using this to implement some of their initiatives in different countries. And we're going to get there, wish that we would more work together. So they are not running in isolations, but, and we'll put some law and order there. But right now, they are just excited and you using the data to implement breast cancer screening or more CTs. But it's not just equipment. We have shown so clearly it's a continuum of care. So I think with May really trying to keep them in line, there is a better tomorrow.
Thank you. And May, what do you think are going to be the biggest challenges in successfully implementing the recommendations of the Commission?
Well, I think there are many challenges, of course, but we want to think of them as opportunities of finding solutions to these challenges. So one of the things I think that really is important is in terms of the planning part of it. It's not about buying an extra machine. It's not about setting up a center. There has to be a lot of work that's done ahead of time. So for example, this is a very good example of how looking at access and the health economic factors are so important. But there are things even beyond that. For example, if you're planning where to put your centers, for example, we do autocorrelation, spatial autocorrelation, to see where the population is and to advise countries where to put the centers, for example. A lot of minutiae have to be addressed. If human capacity building is quite expensive, and that's sometimes underestimated. So how are we going to train all these people in an efficient manner and at a cost that's acceptable? So that's another challenge, but an opportunity. So some innovative IT-based planning using virtual reality and multimedia is something that we've embarked upon, and others and other colleagues around the world are also interested in. We can't keep doing things the same way we're doing. We have to really go to the granular detail of how we're doing things to do it more efficiently. And of course, there's always the research pipeline, which I think Hedy gave very good examples of things that are cost effective and weren't available 10 years ago. So we need to continue to do that, but also to look at our utilization. So there's one thing to add more centers, train more people, but there's another thing about efficiency. How many PET CTs do we need to do in follow-up after lymphoma, for example? And then we have some evidence from clinical trials that are done at the IAA, for example, in pediatric lymphoma and in adult lymphomas. All of these things, patterns of care studies to see how we're doing things. So we have to increase the human capacity. We have to set up centers in a way that looks at it from a holistic view, not only of the number of centers, what they are, but the demographics, the epidemiology on the ground, all of these things, and the spatial correlation is extremely important. And continue medical education, new ways, but also the pipeline for research that's extremely helpful. And the last thing I say, we need political will, because that is another opportunity. And experts around the table really are good examples of people involved in trying to get the word out. A good example is this commission with the movement forward, and of course Lancet and UCAT and David. Without that, we will not move forward. So political will is important, and reaching out to our policymakers and explaining what needs to be done. So right now, the IAA, as I mentioned briefly, has a large, significant new initiative that includes imaging in cancer, and that will be announced, as I said, in February for World Cancer Day. And this would not have been possible without political support from the highest level and from the countries and the missions. And of course, the Director General is very interested, and it's his initiative he's pushing the initiative. So we're very excited. There's so many good things that are happening. We just have to look at these challenges that are everywhere in every country and come together and find solutions and opportunities for them. Thank you.
That's great. All very good points. And the initiative does sound very exciting, so I'm sure it will be fantastic. Andrew, a question for you. What do you think the role is of the latest technological developments, such as artificial intelligence, in helping the implementation of wider access to imaging globally?
Thanks, Kat. Well, clearly that's a very exciting and important breakthrough, which is impacting throughout healthcare. In imaging, as was mentioned during the presentations, the ability of AI to actually assist with the quality control, the workflow that occurs for patients as they go through the imaging process, as well as in the analysis of images after they've been generated, I think is huge. There's research which is ongoing, both at an industry as well as at an academic level, to identify the algorithms which can be best used to improve and to validate their use in clinical outcomes. And I think over the next few years, we're going to be seeing more and more of AI implementation to improve the way in which we can have efficiency and accuracy in the way that imaging is actually performed. The other important point, Kat, that I'd like to make is that I think that somewhat unexpectedly, what's been happening over the last 12 to 18 months with the COVID pandemic may in fact be an opportunity for us to take advantage of the results of this Lancet Oncology Commission. Because now, as was mentioned by Hedy and by May, we have data which clearly demonstrates the way in which imaging can impact on the health outcomes as well as the economic case in cancer patients. And the way that countries, both high-income countries, Western countries, as well as low and middle-income countries, have had to totally change their paradigms in the way that their health systems respond to challenges such as COVID-19, provides us with a, if you like, a template as to how we can try and focus governments and healthcare providers on ways in which there can be a concerted system-wide change in the way that healthcare is implemented. And imaging is clearly a part of that. I'd also mention that it's quite likely that over the next 12 to 18 months, we're going to be seeing a bit of an influx in the numbers of cancer patients at a more advanced stage, which are being diagnosed, simply because the screening and normal pickup and treatment of cancer has been reduced over the last 12 to 18 months. And the way that you find cancer is usually through imaging. And so this, again, I think will be a way in which we can work with governments and also with the international organisations to provide a more compelling case to look at equipment, to look at AI and its implementation and workforce in cancer care.
Thank you, Andrew. That's certainly very interesting to think of the pandemic having a sort of, in a way, helping to bring cancer imaging to the forefront of people's minds, because obviously it's had the pandemic has had such a negative impact on so many aspects of cancer care. So that's a really interesting way of looking at it. May, did you want to add anything about artificial intelligence from the IAEA perspective?
Yes, I think when we think there are two big issues that we need to address when we're thinking of AI, and we have been, we have a new project looking at AI in CTs and to see whether we can predict prognosis and so forth, and hopefully down the road maybe even collect enough data to be able to have to be able to determine early on when you have abnormal patterns, like what we've seen with COVID-19. But the thing that always comes up and concerns us when we're talking about AI is the ethics of AI, because that is an area that we've heard some things about, of course, and there are some discussions, but not always within the medical field. Maybe for social scientists, historians, more than within the medical field as such. And I think that that is a really important issue that needs to be looked at, because you end up with some biases, and depending on the database that it's being trained on, you can have models that really don't reflect what we would like to see as we move forward. So that's one thing. And the second issue that's really important to bring up is some people feel that the AI can do as well as a clinician and all that. It's very important to highlight the fact that it supports, it's a tool, but it's really important to have the expertise, the experience that we're seeing in radiology and nuclear medicine, and not think that one can depend on this, because I've heard discussions about how this could, replace the gap in some LMICs. And it's really important to understand that it could make the physician a bit more efficient, but it cannot make up for that gap. We still have to do it the usual training and education way. So between the ethics part, which we have to be very careful with every step about the impact it could have on areas that we're not really, we don't think about regularly, although there are groups, of course, that outside of the medical field especially, that are really, looking at that in depth. But also the understanding of where to use it. Just like any tool, if it's used inappropriately, it can be dangerous. So we have to keep those two things in mind. And the IAEA we just had a large technical meeting discussing that with many groups, and these are issues that are ongoing. And the document is being prepared as well for guidance, worldwide.
That's great. All very good points. Thank you, May. A question for Hedy. What do you think the main challenges are in terms of implementation? For example, providing PET scanners in very remote areas in low-income countries is obviously going to be a difficulty. So how do you think these sort of problems could be addressed?
So are you asking me about implementations once the equipment has been installed?
Yeah. So assuming you can finance it and get the equipment.
the big implementation, look at the problems we are having with implementations as they're installed in the Western countries. There is always a tremendous concern at training. That's number one. And so we have a training, there's delay, and people. Who is going to work there, how they go, are they properly trained? So now with AI, we always talk about the end service. We often talk about AI, and I cannot agree with May more. It augments what the radiologists are doing, absolutely. I only think, Kate, it will be better and better every day. And if the AI in breast cancer screening performs as well as a radiologist or close to, it's a tremendous service because there is such shortage of radiologists around the world. And then you keep experts because AI also, we need to have formulas, and they are doing it now, where it's like, I don't know, or maybe, but the clear negatives or the clear positives, it's good. So they're going to be a gray zone, and they will always, just like they said, need a radiologist. But it's a tremendous service. The reason I'm saying that, there has been tremendous improvement in software. So when you install a new PET-CT or CT, and there are questions, in so many cases, you no longer need a equipment, a serviceman coming in. It can be fixed remotely. It can be even protocoled remotely. And that is a part of AI that's going to make our life in implementing the equipment, especially in the low middle income countries, much easier. You do need a core technology, savvy people on the ground and technologists, but all the previous service people, engineers that we needed on site, now so often because of the AI platforms, they can do that from anywhere in the world. So they don't need to wait a week for somebody to arrive. It's done overnight. All the upgrades are done overnight. All the implementation of protocolings, all fixing the problem. So that is a big part of AI that we just really need to be grateful for, appreciate, and we often don't talk about that. So my big problem as we're looking, and I'm sure May knows very well, and that is electricity. Continuous electrical supplies, where is that going to go? Because if you have MRI and the electricity goes down, it will take you a long time to bring it back up, to gear it up. So it's I think infrastructure, as we're planning where to put that equipment, is a huge problem. And this is why I am a big advocate of ultrasound, because we have shown that in the low middle income country, just having a simple X-ray and ultrasound makes a big difference. So I would really advise to take small steps, start with really ultrasound, both equipment that's specially designed with them on iPads. I mean, we're trying it in our own centers. It really works. It's not top of the line, but it works for making the basic diagnosis and helps. And so let's start with that. That way, AI again helps, because not only telemedicine, teleradiology consultation, we have to think about how to implement imaging in the low middle income country in a very different way than we did even 5 years ago, and have to get a benefit of different equipment, much friendlier, benefit of AI, benefit of internet and telemedicine and teleradiology, and in education, implement that people that are interested in education and science don't really have to travel to New York anymore. So much can be done through telemedicine, and COVID, just like Andrew pointed out, COVID has taught us, at least in the United States, it's tremendous. Patients love it. Patients love it, clinicians like it, because it's better than just a phone. You see, you talk, you have a conversation. So that modern design of tomorrow for implementing imaging in the low middle income country is very different than what we thought 5-10 years ago. So we need to look into benefiting from tomorrow.
Totally agree. Those are all very, very good points. Yeah, and it's very interesting how, what the pandemic has taught us in terms of what can be done in terms of modern technology. Well, we don't seem to have any more questions here from our side, and we're coming to the end of the session now. So unless there's anything that any of the speakers would like to specifically mention briefly, you have a moment now to do so. Otherwise, I can bring the session to a close. Thank you very much to all of you for your fantastic presentations. It was really, really interesting, and it's been a really great discussion session at the end as well. And thank you to all the audience for attending. I hope you enjoyed the session, and I hope you enjoy the rest of London Global Cancer Week. Thank you.
Perfect. Thank you so much. Thank you, everybody.